Okay, I'm Dean Walker, director of the Geneva Institute and a host of the Hellbender Herald podcast. And we're today going to talk about a very important topic related to medical care and its relation to the Christian community. Thank you guys for joining us. So please introduce yourselves. We have Dr. Dan O'Rourke. Tell us about yourself.
Well, I've been in the medical profession going on 45 years. I'm a cardiologist. At the present time, I own and operate Trinity Heart and Vascular Group, and a large part of our discussion today is the benefits of what we would call a direct pay third party free practice. We'll define that later in our discussion, but that's what we're doing these days. I had practiced many years in an insurance model and looking at it from not only a financial and a medical delivery aspect, but also from a scriptural aspect, I found it to be deficient in many areas. So that led me to have a desire to do what I'm doing now.
Great. And then we have Michael Simpson.
Yes, I'm Michael Simpson. I spent 35 years as commercial banking for a community bank and for a large regional bank. I was a private banker for about 11 or 12 years, worked with lots of medical practices. I have a master's degree in business administration, was an adjunct faculty member at ETSU for about 24 years. I've been interested in this topic for the last 10 or so.
Yeah, very good. So as I was thinking about this topic, I was considering Jesus and the New Testament. And, when he was baptized, and then he went into the wilderness and got tempted, and he goes out. And one of the emphasis of what he's doing is healing. And of course, that is showing who he is, that he's master of the world, he's master of the universe, and he is authority over all sicknesses. But I think there's another important thing going on there, and that is that the healings that he did, and even extending through the church today, is a foreshadowing of a future healing in the resurrection. And because it's a foreshadowing in that way, it's part of the gospel, right? So he's the kingdom of God is at hand, the kingdom of heaven is at hand, and he's healing the people out of the suffering. He's bringing them into a well-being, and in a similar way that Christ heals our sin, right? And so that being such a central part of the gospel, extended through the apostolic age, even after the resurrection, what's Peter doing and the other apostles? Well, they're healing, right? And again, a show of their authority, but also that this is a redemption of God's creation and something to look forward to in the future. So as we think about the topic, I want to suggest that the church should have a central role in healthcare. And we've diverged from that by a long, wide gap. So as we go through our topics today, that's going to be a common theme. But I want to start with Mr. Simpson. And if you could give us sort of a brief history lesson of how we got to where we are today.
Well, the current system really traces back to World War II, and it started with price and wage controls. And so in the midst of the war in 42 or 43, with wage controls, we started having industry compete for workers. And so one of the ways they could compete with workers was they started offering health benefits to folks. So you could get health insurance through your employer. So if you were, building at Boeing an airplane and you were competing with other places, or in Detroit you were building tanks or whatever it happened to be, and they needed good employees, they couldn't pay them anymore, so they would give them health care. And so this sort of slipped into the system. Before that time, people were responsible for their own health care. And so, but this slipped into the system. And what's really sort of ironic about it, the IRS didn't really figure out that this was really an increase in pay until the 50s. And so there was a big uproar in the 50s when they wanted to start charging taxes on that benefit. And so Congress came in and said, no, you're not going to charge taxes on it. And that really developed the system. be quite honest, it worked fairly well. People were still responsible for their health care. But when we added Medicare, Medicaid onto it in the Great Society, then this was like putting the train at full steam and going downhill. And so we've seen since the 70s that we've been on a fast track to where we are today. And so we have one bad government policy of wage and price controls leads to another bad government policy, then leads to Medicare and Medicaid. And so that's sort of where we are today. So that leads into where we are in the Tri-Cities, where we've given a hospital system a monopoly. Now, I'm not opposed to monopolies when monopolies are created by the market independently. So I'm not against monopolies that way. I am against monopolies when the state provides it. So the state of Tennessee, the state of Virginia, the federal government are all culpable in developing ballot. And so in our region, I think it's important to realize it's 1.1 million people that they cover over 29 counties. And so we have a monopoly. And monopolies generally, not always, but generally when they're created by the government, they cause mass inefficiencies. We have people get poor service. And so I think we're seeing those kind of systems. It's my understanding that's the largest medical monopoly in the United States. And so that's where we're at today. And I think that's why finding alternative methods. And if we'll all go back and just look at all the towns that we've lived in, the hospitals used to be run by the Presbyterians and the Methodists and the Baptists and the Seventh-day Adventists and all this kind of stuff. So that's where hospitals started. Like lots of things started. Schools and orphanages all started by the church as a way to show the love of Christ through his people and trying to help their communities be a better place to live.
Is the fact that it's a monopoly the main problem, or are there other significant issues or challenges that we're dealing with?
Well, this area is a unique area. I think we're discovering that this system is not working very well. And so there were lots of promises when we put the hospital systems together that we've not seen. That's not to say that they may not come in the future, but we were hoping to get more medical research. We were hoping to get some other things in this combined system. What would have happened without COVID? I don't know. That's the big thing that's sort of messed up the system. And so in essence, we have a government supported hospital system through Medicare and Medicaid, and then we have really high insurance rates. So we get the worst of both cases. So Friedman, who a lot of this came from, thought that the best solution would be high deductibles or a high copay, or however you want to put it. So you might have a deductible of $10,000, but you have a low insurance cost, and you would cover the catastrophic stuff. And so the system we have now is we all have really high deductibles, and we still have really high insurance premiums. And so when you add the Obamacare with what we've got here, we get the worst of everything.
Yeah.
So.
And we're going to get into some of those specifics a little bit later, but it's worth noting that in where we sit right now, we've got kind of national or more universal issues that relate to some of the history that you went through, and then we have a local problem as well, which relates to the monopoly, and that we have a real lack of options with care, and so we're dealing with those two things locally. So
at some point we need to talk about one of the hurdles that we need to get rid of is the certificate of need. And so if I may, if we eliminate that, which a certificate of need basically gives a medical practice or a hospital system a monopoly in a particular area. And I'll be quite honest, I think the thought process, I understand why they were doing it to ration health care. And because most of the hospitals were not for profit, and we saw this as ways to keep expenses down, but it never works that way. It's sort of like communism. It looks really good until you put it into practice, and then lots of people die. And so in the same instance, knowing that the free market works better generally in the long term. In the short term, it can get a little messy, but over time it really works well. So I think one of the things in the Christian community and the greater community is we should really get with our legislators and let's get rid of the certificate of need. And then maybe we can get a surgery center like they have in Oklahoma that's a cash pay, and that would be great competition, and that would drive up service levels and quality. Competition does that, and it would drive down the price.
Yep. So one of the things that we have that's grown quite substantially in the last 10, 15 years is healthcare sharing options. And I've experienced this personally in that for many years I was working in a corporate environment. And of course, my employer was paying for my health care. I transitioned at some point to more of a contract model. And so I had to provide for my own health care. And then eventually, an aspect of retirement comes into that as well. And I found that I was so immersed in the way that things were being done that I had a real hesitancy relying on the health care sharing model because I was fearful that it would actually step up and pay when I needed to step up and pay. And it was interesting that after I made that step, partially out of necessity, that and was sitting in that, I sat back and realized, well, I'm actually more confident now that in this model that I'll be taken care of when I need it than I was before, because there's so many operatives and risk in the system that didn't have my interest in mind. So again,
And it gets what you were promised before. You get to pick your doctor, and you get to pick your treatment, and you get to do those things. And the only requirement is that with that is you be wise in how you spend that money, because you're spending your neighbor's money like they're spending yours, and you expect them to be wise in it to make good decisions.
Yeah.
So you have to be engaged in your own medical care, which most people are not.
Yes.
Would that be fair enough to say, Dr. O'Rourke?
I would add that's a symptom of the underlying problem that came after.
Sure.
And that's really where we are now is whenever you're not paying for something, if you go to a restaurant and you normally get a conservatively priced meal, but you do that when you're paying. But if you realize that you can force others to pay, you'll pick whatever you want on the menu. The price doesn't really matter. That type of thing. So a lot of the stuff we just talked about in these last few minutes are really symptoms of more profound root causes.
Sure.
Perhaps we'll get into some of those a little later.
Well, I think what I'd like to do right now is transition to what you're doing in your practice.
Yeah.
Because as I was looking for a healthcare medical care solution and in the health care sharing model, I was really looking for something like what you're doing, and I think they work really well hand in hand. So tell us what you're doing and why you were doing it.
Okay. Just briefly, and again, definitions are so important. And that's where a lot of disagreements come, no matter what area of life you're discussing, is people have different definitions for the same terms. But I think it is important, and we've done it here, even in our short meeting this morning. I want to point out to our viewers and listeners that there is a distinction between healthcare and medical care. Those of us who, in the broadest sense, practice the healing arts, we deliver medical care. Health is a state of equilibrium whereby we are not sick. And we can know when we're sick or not sick. There are days we don't feel well, but we don't feel that we're sick. It's like I didn't get enough sleep or I've been under stress. But it is very important. And whether that was a deliberate propaganda move by the medical establishment, that's hard to say, but it is a newer term. I don't really remember it being called that when I started medical school back in the 80s, the term healthcare, because as has been pointed out, health is the responsibility of the individual. Medical practitioners will give advice on prevention and so forth. But actually what I do is most people come to me when they have a problem and they want to have that problem mitigated. So it's medical delivery. It seems like it's a real picayune thing or nuance, but if health is a state of equilibrium where you're well, I can't deliver that. if that makes sense.
Yeah.
Yeah, I don't deliver health. The Lord delivers health.
Yeah.
It's part of our sanctification. And yes, we participate in that. We can treat our bodies in such a way where we become sick more often.
Yeah.
But that's something that I don't do.
It's kind of that now and not yet that I was referring to before. You can't guarantee, although you can help
Yes.
and provide a picture
Yes.
of what's going to happen in the future.
Yeah.
Yeah. But
And ironically, the current system that we're discussing with all of its faults and failures, which are many, they call it healthcare, but they have very little interest in preventative care. They really do. So they talk about how they promote health, but they actually do the opposite. And through it's probably beyond the scope of this podcast, but many of the interventions that have been recommended by public health authorities, nutritionists, and others over decades have actually been counterproductive to good health.
Yeah.
So I just thought that was a good place to start, just to make that distinction. And we all do it, but hopefully in the future we can catch ourselves and refer to it as medical care as opposed to health care,
Yeah, and since you brought up preventative care, let me pause you for a second and make another parallel, right? And that in a similar way that I do preventative spiritual care where I immerse myself in the word and prayer and the singing of songs and that sort of thing, which puts my spiritual self in a frame of mind to engage the world when I'm in it. In a similar way, there's also the health parallel there, that we can do things that helps us in our physical health in the same way we can do things that helps us in spiritual health. So and so emphasize that preventative care actually is very important.
Yes, it is. We're trying to prevent me having to deliver medical care to you in the future.
Sure.
Yeah, that's a good thing.
Wouldn't you say one of the implications of having the current health system is that because people don't take a hands-on approach, they probably do more risky activities than somebody else?
Definitely part of that, like you said.
So
other people are paying. There's no.
So you get overutilization, and people think it's sort of like your restaurant thing. Is we're at a buffet and somebody else is paying, and there's no implications for me. So I eat everything, regardless of the cost to somebody else.
Right.
Sure. Okay, please continue. Tell us what you're doing.
So for most of my career, I practiced in what we call the insurance model, but one of the advantages of being a seasoned practitioner is you've spanned a period of time where you've seen both sides of the creek, and what has changed. And, back when I started in the 80s, I was in my training, but watching the private practice docs. Back in those days, virtually all hospitals were private. They weren't part of any consortium. They competed with one another. But competition is so important in all areas of economic life because competition fosters excellence and it fosters lower prices. And so when we moved away from that model through government programs and so forth, that started a downward spiral. And through my career, I began to see it. And then I think it was 1993, Congress passed the HMO Act, or 73 rather. And that again started the paradigm of managed care and, getting to root principles. And again, many of these things we talk about today could be separate podcasts in themselves. So we'll have to restrain ourselves. But again, the really fundamental question is, we as Christians, and many Christians have not been taught this, but we've alluded to it here, Christ is the king of everything. He's the king of the world. He is the king. He's prophet, priest, and king. And basically what has happened is we have had competing religious systems develop. And one of it is what I've termed the messianic state or statism. And as a consequence, God's word really does not give the state any jurisdiction over medical care or areas of the economy, that type of thing. For the interested reader, Romans 13, 1-6 really talks about the very limited duties of the state. And they're important duties. But again, redistributing wealth, telling people, occupational licensing, all of these types of things are counterproductive, not only just in the medical community, but in many areas of life. I think 40% of all jobs in America now require some sort of licensing. And so these things are also very counterproductive. So those are the root causes. But the scripture does speak to these things. And
Yes.
the church has sort of created a dual thought process here, which is really sub-biblical in the sense that, well, yes, Christ is the king of my soul and my church,
Yeah.
but the social order is sort of over here and it's neutral, and nothing could be further from the truth.
Well, and let's pause for a minute. Where does the Bible, particularly in the New Testament, teach us to go when we're sick?
Yeah.
Where does it tell us to go? And particularly in the book of James, I think.
Yeah. Well, you talk to the elders.
You go to the elders
Yeah.
and they pray over you.
That's the start of it. Yeah.
Yeah. So, and of course, that doesn't say that we don't seek other means that are there, but it does kind of orient and where should we, what realm should we take our health issues?
Yes, exactly. And in a parable, it was talking about sin-sick souls, but Jesus said, well, you go to a doctor when you're sick in a parable. So he was using that illustration that when you feel like you're physically sick, you go to a doctor. Likewise, you seek the Lord when he opens your eyes and you realize you're sin sick. And that you're completely correct. Those are two very tightly related issues.
Right. Can we get on a rabbit trail with the licensure thing? Friedman talked about that licensures, as we know, it limits competition, it limits innovation. It, in a sense, we could use the word, it makes it like a union, right? So then you get all the negatives, but not a lot of positives from it. And he postulated that we should go to a certificate system that would work where the person was trained. So how do we get from the licensure systems to this? So just as a note, the typical, and I'm making a guess from previous knowledge, but the typical medical student comes out of medical school with three or four, $500,000 worth of debt. And so I'll say this crassly, they've already had to sell their soul to the devil just to pay their debt back. So that the system's not working on the end for the people who want to be doctors. There's not enough medical schools. There's not enough doctors. We want to get the price down on that side of medical care, which I don't think is the problem. Personally, I think it's the administration and insurance is really the problem. But how do we fix the licensure problem, or is there a way to do that?
Well, it gets back to some of the basic principles. And again, we live in the world as it really is, not how we hope it is, but there is a scriptural template here. And all the things you just mentioned in a serious-minded, thoroughgoing biblical culture, none of those things exist. Licensure and deciding how many the market will determine how many med schools we should have. And then one of the very grave errors in our country, some people refer to it as the Rockefeller medical model, but in 1910, long story short, with the Flexner Report and other things, they basically tried to eliminate all other medical paradigms as opposed to the pharmaceutical based.
Yeah.
And there are benefits to that, of course.
Right. And as a personal example, in the last 2 or 3 years, I struggled with elbow injuries, actually on both arms. This one's much better than this one right now. I was pretty sure that I knew what was going on, and I really didn't want to go to an orthopedist. I knew I didn't want surgery. Right. And so what were they going to do for me other than that? And I was pretty sure I knew how to handle it. But what I would have done if it was open to me would be to go to a qualified nurse and pay them a set fee that I knew going in ahead of time to tell them what had happened to me and what I was thinking, and to get, in essence, a second opinion for myself, so that I had some confidence, or more confidence, that I wasn't going down a wrong path and trying to self-treat. But in our current system, that's not open to me in most cases.
Very difficult. Yeah.
But what you're doing helps with that.
Yes.
So walk us down that path.
So practiced for many years in the insurance model, and the first 20 years, I admit, it's lucrative for the physician to be in that model. Incomes are high and quality of life materially is high, those types of things. But as time went on, we made the phrase, which is so often used, but appropriately so, in a figurative sense, you sell your soul to the devil, but we always say strings attached. I'd call them ropes and chains, that are attached to these things. And basically when that happened, now we began to see insurers really abjectly violate state licensing laws. Now, again, we're opposed to those in principle. We do have them, so they should at least enforce them as they are. but you would have an insurance company, and this started in the 90s, and it baffled us because that was called prior authorization. And physicians said, well, this is what I want to do. This is what I think I should do. And some insurance companies telling me that they're not going to authorize payment for that. And so you begin to have prior authorization, restriction and access and care there. And then, of course, you have algorithms as to how we treat things. Well, this is how we treat pneumonia. Well, maybe I want to treat pneumonia this way, but that's out of the narrow treatment paradigms.
Sure.
And a lot of these things are really, really done by pharmaceutical industry, government, public health agencies, but they're not really done by a true medical care delivery free market. Because people do have the right before God and man to seek different options as to how they might want to handle their various maladies in a fallen world. And so, well, this is acceptable, this is not. The state's role there is really one of fraud. If someone says they can do something and then they had no training, it's not that they're certifying the person, but there would be in a private sector. It's sort of like Underwriters Laboratory. It's a private organization, but if you buy an electrical product with a UL label on it, generally speaking, it's safe and pretty good. And those types of things would develop in medicine too. But in any event, these are some of the factors that began to weigh on me. And then probably the biggest push that made me move to a new model was the corporatization of medicine, where now probably it's estimated that 80% of physicians are now owned by medical conglomerates. A lot of our physicians in this region are employed by Ballot Health. There are larger private organizations, multi-specialty groups, but even they are sort of forced to pay to play and follow a lot of regulations. So I just wanted the freedom to, practice medicine in a way that allowed me time to spend with the patient, but also to offer it at a price that is based on a true pro forma where, okay, what do I want to make? What are my costs to deliver that? And then you set the price. I've told this story many times. There's a man I know, this was about 10 years ago, but his son split his chin open and he was taken to our local hospital and it was 6 stitches for $1,200. A friend of mine he's in primary care with this model. He and his wife have never been in a insurance model. And I shared this story with him and he said, yeah, we do that in our office for about $40 or $50, So we can see the direct harm to patients and the access problems. So what I did 3 years ago, we're almost on our 30th anniversary, is I left the insurance model and the corporate model. And I founded the private practice of Trinity Heart and Vascular Group. And we're an outpatient cardiovascular medicine practice. And we do entry-level evaluations and chronic disease management. We do basic testing and so forth. But we did apply those principles of a proper pro forma. And as a consequence, we can offer more time to the patients, but we can also offer them basic testing at very affordable prices, usually about a fourth of what you might be charged at a typical medical system. So that's part of what drove me to do this. And of course, the Christian aspects as well, those are very, very heavy. And that's why we call ourselves Trinity Heart and Vascular Group. The Trinity part is deliberate. We did that because triune God is the one who saves us, not only physically, but spiritually. So.
Sure.
So another problem with the system, I have a good friend that's a pharmacist, the pharmacy benefit managers.
Yeah.
So their goal is to maximize profit. So their goal would be to make sure that you get the most expensive drug you need, not the most expensive drug that's in their formulary. So I'll disclose that Dr. O'Rourke's my doctor, and we've talked about different medicines. He goes, oh, this one works, and it's very, very inexpensive. But if you were going through the regular system, they would force you into a more expensive drug, which causes the price to go up. So it's so lucrative. It's my understanding that CVS pharmacies in Arkansas have the PBM. They moved to this model before their competitors. And the state of Arkansas passed a law that says you can't have a pharmacy and a PBM. So they closed all their pharmacies down in the state of Arkansas, every one of them.
Wow.
Because it was more beneficial, more lucrative to do that.
Manager.
So just as a note, I love my local pharmacist like I like my doctor. They're very helpful with you on this stuff. But if you have insurance, ask them what the cash price is. And ask your pharmacist if there's an alternative drug. It's a fair question. And they can say you could do this and you can go back to your doctor and you might find that you could drop the price a lot, which is part of what we want to do, right? Be good stewards of what we're given. But I mean, when I was in the insurance model before I retired, I would always ask him, what's the cash price? Is there an alternative? And he was really good. And he goes, oh yeah, the cash price is $30 less than what I was paying as my copay.
Okay. So let's try to make a distinction here. Help us work through this, because I think that in Dr. O'Rourke's practice, that he wants to make a profit too.
Right.
Right. And I know you have Christian service mind, and a lot of that's going on, but a doctor needs to be paid for his work, right? So to be in business to make a profit is not a bad thing. So how is this different? Why is the situation that you're referring to, how is it different than?
I think, well, first, Dr. O'Rourke wants to make a profit, but he wants to also provide the benefit that goes along that in a fair and equitable way.
Yeah.
Right. Okay. I'm not saying they're not doing it in a fair and equitable way, but it certainly appears when they force you to go to a more expensive drug or a more expensive model, and when the cash price would be less than what's going through their formulary, that seems to be, in most cases, when you do that, that would not be, I don't want to use the F word, the fraud word there, but it does seem unequitable.
Yeah.
Right? And so, and part of this is it really puts the pressure on the local pharmacist to not be able to provide the service that they would like to do, like Dr. O'Rourke would. So I'm not adverse to the profit. I'm adverse to the fact that the way you lead the profit is provide the appropriate service. So my mantra as in my career, I always want to sell the product the customer needs, not what the product that makes the most money for the institution. And then that way, that's the right way to do it. So I might sell you something by accident you didn't need.
Yeah.
But it was out of ignorance, not out of malice.
Yeah.
And so I'm not so sure that when we get these big institutions, that the profit motive, which is a good motive, can be manipulated. So as much as I like Milton Friedman, I think he was wrong in the sense that your first goal should be to provide the right service and make a profit off of it. It shouldn't be your first motive should be to make a profit, however you get there.
Sure.
And so there has to be a Christian ethic in that as well.
And I think you just hit it right. The Christian ethic comes from a Christian worldview, because I don't want to make a claim that capitalism is completely neutral, but there is a neutral aspect in it, right? That depending on the situation, it can be done within a Christian ethic, with both parties seeking to do that in a responsible way, and it can be done in an abusive aspect.
I would use a different term than capitalism. I would use free market.
Sure.
So we could have an exchange. Capitalism is like democracy. It's a word that's got all kinds of meanings, and that we could spend weeks trying to decipher what it means. But free market is pretty simple. I choose to buy something, you choose to sell something, we come to a meeting of the mind, and we're as honest and forthright as we can be. And if the market works right and you go to for instance, a pharmacy that's not treating you that way, then you're free to choose and go someplace else.
And so I think one of in the medical care industry, right, the patient, I think, is particularly vulnerable. Right. There are some times where we're in these free market exchanges where we're informed to higher degrees than we often are in the medical, because we're getting expert advice in many cases from the person who is actually going to charge us the fee. And so then I think we're looking for an element of trust, right? And I would say that Dr. O'Rourke's practice is good in this respect because it's done in a way that I can trust it. And so you'd ask the same question for Ballot or whoever is providing the service, right? It's that.
Here's a good example of a limited insurance model is with dentist, right? And so trusting your dentist it can become very obvious. So I have a dentist. He's a great guy, fabulous dentist, and I trust him. But your dentist can make a suggestion on a procedure that you don't need.
Yes.
And so if at any point I feel like out of malice, my dentist suggests a procedure, I can always go to another dentist and have it checked, right? And we as a family have personally experienced this. My wife has a different dentist because the one she had before, did services that we didn't ask for on the children. Like, so the dentist provided a fluoride treatment and we didn't authorize that. And so we said, well, we didn't authorize that. Well, blah, blah, blah. No, we didn't authorize it, right? So we changed dentists. And so she goes to a different dentist now. And so it's really obvious in that model because it's easy to go check. And in some of what, in the rest of the body, it's not quite as easy to check. So trusting your provider makes a huge difference in this. And again, where the Christian ethic would come through. Now, my dentist is a Christian, and I know he's a Christian, and I've met him and his wife and his family. Really, really great people. And the dentist that Caroline now has, I know that guy, really great dentist, has a good history, good reputation. And so that it's obvious there to people, if you would treat your family practice doctor like you've treated your dentist and be more careful about what they're thinking about, I think that would be a good, people understand that model. Do you follow what I'm saying? Because we've all been to a dentist and say, well, you need to do this, and go, I don't think I need to do that. And you'll question your dentist where you may not question your other doctor, which you should do.
Or an automobile mechanic.
Oh, well, yeah. So that's a whole different subject. Yeah.
So, okay. So we kind of interrupted you. Pick up the story.
These are very important points, and these are all motivating factors too,
Yeah.
And just to weave what Michael just said into what I'm doing, but it just goes to show you the dangers. We used to call it mercantilism, but basically it's just an old term for protectionism and barriers to entry. And that's a huge problem, not only in medicine, but in many areas of the American economy. You have barriers to entry, and then that leads to sort of favored nation status for certain businesses. And so that's a very, very serious problem. And getting back to the profit is a very biblical concept. But everything we do in life must be fenced by the law of God, including our profit motive. So the beauty of my model, and it's not my model, it's been done for most of human history, actually, especially in Christian nations. But if I get a reputation, when you go see him, he's going to order a heart monitor, an echo test. He'll check your carotids. He'll do an echo on your heart. He'll do a stress test on you. Now, very few people need all of those at one time, but there are doctors that they've done that. That's what they do. But you will quickly, in a free market system, you'll quickly get a reputation if that's what you're doing, and then you'll fall out of favor. So as I said earlier, if you want to thrive in these types of models, you must strive for excellence, and you will do fair pricing. Now, obviously, right now, for many of the things I do, my fees are lower than you would pay in most circumstances. However, I have a good friend. She's in a private practice, and there's a certain condition that she treats, and the Blue Cross they're only paying her $64 to treat that in the office. Well, that's hardly enough to keep the lights on, so it cuts both ways. I can see a time when for certain things I will not be the lowest cost, but you don't want your provider to feel like that they're like you said earlier, there's a training and there's a certain value to what you do. I have many years of training into this, and how you value that is somewhat subjective, but I do expect to be paid accordingly. There's a commonly performed procedure we do called an echocardiogram. It's a cardiac ultrasound. We charge $200 for that, which is a very fair price compared to what we normally see paid in our society. Having said that, I will not do an echo for $50 because I'll go broke if I keep doing that. But also it doesn't value, that's the other Christian part of it, part of the commandments is we are to value the skill that God has given certain people, whether it's a mechanic, a carpenter, banker, whatever, and we don't want to rob from them and pay every man his wages.
Yes.
And so to pay, you have a professional engineer, for example, and he designs a structure, and it was very complex engineering, so the building doesn't fall down. To pay him $20 for that is ridiculous. We wouldn't do it. He wouldn't allow it, but you get the point.
Right.
So that's what really led to all this. And then the old cliche, but it's true, you have to walk before you run. But my goal and my prayer is that I don't want this practice to die when I do. I want it to carry on in a covenantal means. So probably talk about this a little later. How can we get more physicians involved, and why aren't they involved right now? We can discuss that later. But again, getting back to the hospital models, the care for the moderate and severely ill, there's more than one way to approach that problem. We've had private discussions, back when the Christians developed hospital systems, they mainly were for the poor. And it was a good system, and many physicians would tithe their time. They would just say, hey, it's a form of tithe, I'll go and help, and so forth. But again, what it actually would look like is hard to know. But one thing I do know is the current 500-bed brick and mortar hospital system that we've had for the last generation or two, that's a dead model right now. And it's not necessary, and we can move on from that. So we do have bigger goals for where we're trying to head here. We had mentioned certificate of need. Our legislature has passed the law, and I believe it was signed by the governor, where over the next 5 years these things will be phased out. That's only a first step. We still have the regulatory apparatus to deal with. That's a huge problem as well. But at least it becomes lawful to, if I want to open a cardiac cath lab, I can do so. And the risk is on me. And you said earlier, they did these things because they wanted to try to cut back on utilization. But why was there high utilization? Because somebody else was paying for it, right?
Right.
So all these things feed on themselves, and the scriptures do speak to them. And when you violate biblical principles, sooner or later, you're going to have problems.
Well, it occurs as a discussion you and I've had in the past about we have a demographic problem where we have all the baby boomers are moving through this system.
Yeah.
And I've talked to physicians that I'm friends with, and a physician down at Knoxville that I was seeing, really, really great guy. And I said, and we had this discussion. I think that it plays into this view. So, in 10 years, you're going to have less patients. Urologists and cardiologists, because this older population is going to go away. And so, and the guy goes, well, how do I compete? He says, well, how we used to compete, you compete on giving great service. And great service starts at the person who you walk up to the counter with.
Yeah.
The doctor can be the best doctor in the world, but if his staff is not, polite, and I think that's going to be a problem for these mid 40 to mid 50 doctors that usually deal with older patients. As those people move through the system, I think we're going to see a little bit of payment adjustments because there's going to be more doctors than there are patients as we're used to. And so that might be a great opportunity to move to a different model.
Yeah.
Okay. So if I come to your office, I understand that I can actually go to your website and pull down a fee sheet.
Yes, you can. Totally.
So you're telling me that as I make this appointment and I go to your office and I go home and I get the bill, that I know exactly what I'm going to see.
You actually won't get a bill because you'll pay me before you go.
Fair enough.
Yeah.
But as I pay before I go, I'm not going to be surprised. I want to know that ahead of time.
No, yeah. We are required by law to give what's called a good faith estimate, but ours isn't an estimate. Disclaimer, we do have on our fee schedule, fees are subject to change, which I'll notice, so there could be a fee change in between the time you schedule there. But it's not like it was $200, now it's $1,000,
Right.
That doesn't happen, might be a $10 or $20 difference, but
That's just such a huge shift.
Yeah.
Is that, I think people expect these days that they go and then the bill shows up, and it's often shocking, but they have no idea what it's going to, particularly if you end up in some sort of emergency situation. Yeah. So that just seems to be so much better. Is why would you do it one way versus the other way? So as I'm checking out, I'm going to give you my insurance card, right? And then you're going to run the insurance.
What are insurance cards? No, the only time we collect insurance cards is when someone wants a procedure we don't do, or they would prefer to run it through their insurance. We'll refer them to a provider who will take their insurance, and oftentimes they want to know that information. But that's the only time we collect those things, yes.
Yep. So, but how do I pay them? It sounds good, right? I go to your site,
Yeah.
I know what I'm going to pay, but my insurance, it's not going to go through the insurance. So what do I do?
You pay. You prepare It's another thing that's been lost in our generation is the concept of a rainy day fund, and I could get sick. I might have to. My own personal life, we found out a few weeks ago that our roof was shot. Well, I had put money aside, and it's a big bill, but we had prepared for these things. And that's also part of, the Christian aspect of society is keeping your house in order and that type of thing.
So this is what you mean when you say direct, no third
Right,
party.
that means the patient pays us directly.
Right.
There are different ways that's done. We have a fee schedule. Some primary care doctors have what's called a subscription model. You may pay in our region, because we're more of a low cost region, you may pay $80 to $100 a month, but you do get very good access and prompt service, and basic blood tests are often included in that. And then there's a more comprehensive model called concierge, which we've heard of, but that's where these doctors might only have 200 people on their panel, but they'll show up at your house at 2 o'clock in the morning.
Right.
If it's not a dire emergency, otherwise you might truly need to go to the emergency room. But other than that, they'll make house calls and you pay a higher premium for that. But you definitely get what you pay for in those models. But in all these ramifications of how it's done, the provider is paid directly by the patient.
Yeah. Okay.
Are we
So-
going to see? Are we going to see more of this concierge type medicine?
In some parts of the country where there's a higher affluency, concierge, I'm not really sure we have any true concierge here in Tri-Cities because it's $2,000 or $3,000 a year up front, typically. Sometimes 4,000 if you're in LA or New York City, things of those nature. But
Right.
the subscription model, especially if you have a chronic illness and you may go for care 4 to 6 times a year, that's a very good bargain.
Right.
Yeah.
So doesn't this lock out a lot of people from?
We have many people, who are what we would consider poor who come to us and they're able to pay. We do have the option, and we have done this, render some charity. Although admittedly our fee schedule has that in mind. So we do our pro forma based on, we do factor in ability to pay, that type of thing.
Right.
But even in the most dire of circumstances, totally free anything to the poor is not a good idea. There always has to be even some skin in the game, even if it's $20, that type of thing. And years ago, I read a wonderful essay by Dr. Joe Morecraft, great Presbyterian minister. It was called The Reconstruction of Medicine. And it was just a wonderful essay, but at the very end, he made some brief comments on, well, who's responsible to pay the doctor? And actually, he showed in my mind, he convinced me biblically that charity is one of the last options I have. There are other people that are responsible to pay before I am.
Sure.
The scriptures clearly say that if we don't care for our own, we're worse than an infidel.
Yeah.
So, like, let's say my mother, for example, admittedly she has Medicare, but let's just say she didn't have that. It's my duty and my sister's duty to provide care for her.
Yes.
Before anybody else. And then you go down the line and the church may get involved. And
Well, let's talk about the church there for a minute, because I want to bring a couple of.
Can we define charity first? I think it's a word that's not used appropriately.
Yeah.
And so charity would be, if we took a different century's view, and so I'll use this as an example. So Dr. O'Rourke provides charity for a patient and they're unable to pay, but I'm going to use this, but they were able to chop wood for Dr. or clean his office or do some other kind of task to pay for that. That's still charity.
Yes.
Yes, it is.
And there is this thought in the society where, well, if you have to do anything for it, it's not charity. And that is just a wrong thought.
Uh-huh.
And so I think we need to encourage people that when you're helping them to have some kind of expectation of something that they do. So the practice at Westminster Presbyterian Church here in Kingsport, if somebody needs help, the expectation is you have to come to a service. That's very, very low bar.
Right.
Yep.
I mean, that's a very low bar.
Sure.
And most people don't want to do that either.
Exactly.
Okay.
Yeah. So I do want to mention, well, what is the role of the church here? And I want to draw from two different passages. One of them is Galatians 6, where it tells us two principles there. One is to bear one another's burdens, right? And so it's not specifically talking about healthcare, but but that would be inclusive,
Sure.
right? That when there is a burden that needs to be borne by the wider community of believers, that they do that. And then later in the passage, it says, carry your own load, right? And that load and that burden are actually distinct words. One of them implying something that's extremely difficult to bear, and the other one kind of implying something that you should throw over your shoulder and carry as you walk around. And so there's a principle that we provide for ourselves, right? Rainy day fund, whatever we need it we do plan for that and we do it. But when we have something that's burdensome, then the principle is that the church will help bear that burden. And then the other passage I wanted to draw from is Acts 2, where we actually see that in practice. And it gives a very short picture of life in the church where says they had all things in common. And as people had need, they were selling their property and other things in order to provide for those needs. Now, some people take that too far and want to take it to socialism, and that's not what it's talking about. It's talking about that people were using the means that they have in order to bear the burdens of the other member of the fellowship. And so I agree. Is that there is a family responsibility that is clear. We could go to scriptures for that as well, but then there's also a church responsibility beyond that, and I kind of want to say that's where it stops.
Can I give you an example? So when Carol and I were first married, Pastor Bradley's father, Gene Bradley, had his kidneys were failing, and so he was at the end of life circumstance. And so Pastor Bradley asked the church to volunteer to stay with Gene those last weeks of his life to help Connie out. So Carol and I, newly married 4 or 5 months, so 2004, 2005, whenever it was. So we went to their house and we took a 4 hour shift to sit with Gene, who was comatose. He couldn't speak. And then there was Connie, his wife. And it was I mean, I get teary about it even today. It was such a blessed time. She told all the great stories from their life and their marriage. And we laughed and we cut up. And so here's a man on his deathbed where his wife was sharing the joy of their marriage. And so what a great example of Christian charity.
Yeah,
Exactly.
right. And as we were talking about, in my mind was just contrasting that with what we saw in COVID, where people weren't even allowed to come in, and the family members were not even allowed to be there. And so that contrast, what a difference a Christian worldview made. How are we going to prioritize these decisions? Well, there are things that are much more important than the possibility of transferring a sickness. There are things that are much deeper and much more important than that. And a Christian worldview recognizes that.
Well, you do see, as both of my parents passed away, and we showed up at the hospital and we took them home. And it was a good example that Pastor Bradley's mom and dad had said, and of course my family would have done that. But the people in the hospitals and the places are amazed that people were still willing to do that. And I could never remember in my greater family where there's not that many Christians, but that ethic is still there. It's our responsibility. And sometimes people die in a hospital, but we're in those end of life things. Why would you want to die in the hospital?
Yeah, it's a good
And
question.
and let's take a step back from the emotional part of that and how good that was from all of our family, the appropriate type of pride for doing that, but the economic benefit for not wasting the resources of other people. And we didn't do it because of that,
Right.
but that was the consequences, not the unintended consequences. And so, and we made decisions for my mother and my father based on, well, no, we're not going to do all this. It really doesn't we want to extend my dad's pancreatic cancer, we want to extend his life by a month, and it's going to be painful and ugly. And why would you do that? My mother had heart failure. Sure, we could have taken her to the Mayo Clinic or someplace and done it, but you get another so many months. Why prolong the agony? My mother was a good Christian woman, and she said, my time has come.
Yeah.
And I think that is one of the great unintended consequences of the current system we have. We put death responsibility on somebody besides the family, and we should be responsible for that.
Yeah.
And I understand sometimes people will die in a hospital, but it should be not the norm. Would you agree?
Yeah.
And so we should strive to do that. Part of the training, which I've not done a good job with my own children, is my expectation is if you can bring me home, you should bring me home.
Yeah. So now we're getting into this is, I think, one of the key issues in the way that we think of medical care in general, but also in the church. There's a question here. As Christians, do we believe in the resurrection? Do we believe in the resurrection? Does it actually change the way that we live? And if we believe in the resurrection and it changes the way we live, then we understand that extension of life is not the highest thing. If you take the Christian worldview out of medical care, then the extension of life becomes almost everything because there's no after.
Right.
And so what's going to drive your practice is whatever you can do to extend life. That's the primary thing, because after that, it's over. But the Christian worldview says there's a resurrection. And if we actually believe into that, then that leads us to prioritize things that we wouldn't prioritize otherwise.
Well, and here's the thing, it sounds hard, but it's really not hard. If we're standing here, and I'm going to use a absurd kind of thing, and so I will qualify this. If you're 25 years old or 30 years old, and you have a young family, and I would encourage somebody, given the circumstances, we should try to do everything we can do. There's a reason for that. There's so many great responsibilities. But my dad, in that case, who was 72 years old, and we made the right decisions, good. But when you're standing there and you've got somebody who's at the end of their life, and we all know it, and we take good counsel from physicians, and we can tell, and you're standing there, and they say, well, do everything that you can do to save them so that they can live another month. And say, okay, we'll do that. We're going to take it out of your estate.
Yeah.
And you're going to pay for it.
Yeah.
And so the person who is sick, if they're wise, will look at their children and go, why are you doing that? Because those resources would be better used for other things.
Right.
And so knowing that we're going to be resurrected makes that decision a lot simpler, right?
Yes.
And so I think a hard conversation that families have to have is you have to have at least part of this on the front end. And so, and I do think station of life and time in life makes a big difference. I mean, if you're a 35-year-old guy with a bunch of little kids and you've got some fatal cancer that, is only a 7% chance, that's a different decision than if you're 85 years old. And people go, well, that's just wrong. You shouldn't look at that way. Well, yeah, you should. That's okay, right? But we won't make those hard economic decisions because we don't pay for it.
Yes.
But if you were paying for it, you would make different decisions. And the person who was dying, particularly if they were Christians, would make a different decision.
Right.
Right. And so that's the hard conversations you have to have. And so, and sometimes doctors, in my dad's case, I think it's a great example, had a pulmonologist in Bluefield, West Virginia, fine doctor. And he told my mother, Mrs. Simpson, your husband's dying. There's nothing anybody can do. Well, that's a great mercy. He could have come in and said, well, we can do all these treatments and we can go to Duke and you can try all this stuff and we can spend the next 30 days doing all this and the outcome's going to be the same.
Yeah.
But and I'm sure he wasn't Christian, but his answer was honest. So honesty can cut both ways. And so I think that's the discussion, particularly that the church needs to have. I think Pastor Bradley has talked about this from the pulpit years ago. And we really need to make sure that we make the right decisions at the end of life because it's such a good example.
And I think it's useful. It's didactic. It teaches us if we make those decisions personally. When we shift it out to an insurance company to make all those decisions for, we don't have to lose. We lose. We lose control over our lives. We lose an understanding of what life is all about.
And it's good to, Dr. O'Rourke and I talked about it, my family practice doctor, when I was in the insurance model, I had to remind him that I was the patient and the insurance company was not. And I had a very excellent family practice. I really liked the guy, a good fellow, but I think if you're in that system, you need to remind the doctor who the patient is. Because, well, the insurance company wouldn't let me do that. And say, well, I don't care what the insurance company is doing. I'm the patient.
Yeah.
I'm the primary person that makes this decision, not the insurance company. Well, they may not pay for it. Well, I want to do what's best. And I think that would help change that model, at least reform it a little. Would you agree? All right.
But
Okay.
I like that too. What we've just talked about is vitally important, but we also have to realize for Christians to guard themselves, the loss of a belief amongst the medical providers of a resurrection can have dangerous consequences for you as a patient.
Yes.
Because, well, this is all we have. We're materialists. We're going to just hang on forever. But then there's a large hubris. We're in a very dangerous time in medicine because there's many wonderful technologies and discoveries, but for example, genetics, what we really know about that is very little, very little. And there's very much in the way of problematic methodologies. And a lot of what we're told as to what the research showed actually didn't show any such thing, But again, some of the proposed therapies for things that they talk about what's called CRISPR technology, where they think that they can go in there and snip bad genes out and put better genes in, And I would avoid those therapies at all costs.
Sure.
But my point is to be taken is that we have to be careful to at least pay a little attention to what is the worldview driving your medical care. Mm-hmm. And it's not a sin to go to an unbelieving doctor, and there are many good doctors who are not Christian, but it is helpful but there are many unbelievers who are physicians. They may not be Christian, but they somewhat operate under a Christian worldwide view, and that's what you want to see.
Sure.
We won't sidetrack ourselves much for COVID other than to say there's great controversy as to what was that all about. But at face value, we were told this was an existential threat to mankind. And the response that actually was done globally and here was not a Christian response.
That's right.
Because what we've been talking about, well, there's no resurrection. We got to do this.
Yeah.
Well, back in the plagues, Geneva, they tried to encourage John Calvin not to visit the sick. Well, he didn't listen to them. He did anyhow.
Sure.
But again, that was the attitude of clergy back then. Well, that's just our duty.
Yeah.
No matter what you thought, closure of churches, things of this nature.
So duty, obedience,
yep.
Love of neighbor,
yep.
Love, all these things are driving your decision that override what the consequent might be.
Right.
And knowing from a Christian worldview that whatever the consequent might be, it's as nothing in relation to what comes after.
Right.
And that's where we put all our hope.
And it's medically factual too. Yes, you can expose yourself to a medical risk, but it's amazing. We call it the attack rate for what we presume to be contagious illness. And they're actually quite low.
Sure.
They typically are less than 20 or 30%, Some think, and it did seem to be measles back when we used to get that a lot, it seemed to get people a little more often. But the point is, you have an 80% chance of not getting it, even though you're sitting right next to the guy who's breathing on you and coughing on you.
Right.
And if you believe in a resurrection, well, then your duty turns to the care of your neighbor as opposed to worrying about your life expectancy is in the Lord's hands anyhow.
Sure.
Which isn't to imply recklessness, but it's to be measured and guided by biblical principles.
Okay, so that's good. I want to shift the conversation.
Okay.
I did a little bit of research. I consulted the intelligence in the cloud. And that intelligence gave me a list of issues.
Not the cloud, a cloud.
Yeah. Yeah, it gave me a list of issues with our current medical system, and I want to do a quick comparison. I want to walk down. It gave me a list of 10. I want to walk down them. Some of them we talked about already, but I want to compare what the norm is today, which is an insurance-based model, versus what you went to, which is a direct pay, no third party model. And I want to analyze each of these issues and to what extent this model, the direct pay, no third party model, alleviates those issues. Okay. Got what we're going to do. We're going to walk through it. Okay. The first one was high administrative cost. So how does it help? How does a direct pay, no third party?
You really eliminate a lot of necessary positions that you must have in the insurance model. For example, if I would have left Ballot 3 years ago and decided I just want to do private practice, but I want to stay in the insurance model, I would have had to hire 1 or 2 employees at a cost, if it was two, between $80,000 and $100,000 a year just to do prior authorizations, file insurance claims,
Right.
get the money. As those of us who are familiar with business principles, you have what's known as an accounts receivable. It's money you're owed, but you don't have yet. See, in my practice, very rarely do we have an accounts receivable. We
Sure.
occasionally do, but all that has to be managed. So clearly, the direct pay model clearly reduces administrative costs.
Now, and I want to add to the direct pay model, right? So if I then marry that to a cost sharing model like Samaritan Ministries, if I put a circle around that saying that's the solution, don't I have that administrative cost inherent in that cost sharing?
There's always a cost to doing business, no matter what we do. And even Samaritan Ministries, with my wife and I participate in, I think it's once a month. I think one of your 12 monthly shares goes to their administrative costs.
That seems to be relatively low.
Yes.
The January one.
Yes.
So in practice, we were seeing that the administrative cost for something like Samaritan Ministries is much lower than what we're seeing.
Yeah.
Okay.
Plus you get the added benefit that the people you send a check for, you should be praying for them, at least somebody.
Absolutely.
Yeah, I like that aspect of it too. Okay, number two. And some of these things we might want to discuss how concerned we are about them.
Yeah.
But number two is lack of universal coverage.
No one has a right to medical care.
That seems very harsh
Yes.
and unfeeling.
Yes.
Can you help me with that?
Yes. We have several principles in the ordinary course of life. The right to medical care is not absolute. If we want to follow Good Samaritan principle, and our hospitals do, and that was, some of the questions. We've sneak peeked a few, and there was some implication by the cloud. No one is turned away, even in our current system. If you get hit by a car up in Stone Drive, they will take you to Holston Valley. You could be the poorest guy in town, you could be the richest guy in town, you will get treated.
Right.
Where we sort of lose sight of this is you will get the care, but that does not obviate the responsibility of payment for that care.
Yeah.
And so we are, as part of keeping our life in order, like we have a rainy day fund, we also take a consideration of, okay, if I do have a sudden illness by the providence of God, how am I going to pay for that care?
Uh-huh.
That never was really a huge concern as little as pre-World War II, because everything was pretty cheap. And so you just save the money up and you can pay. And there was bartering during the Depression. A lot of doctors, they had to eat too, so they would provide medical services for chicken or eggs or whatever, that type of thing. But again, no one actually has a right. Rand Paul had talked about this a few years ago, where he basically said, well, you basically turned the physicians into slaves.
Yeah.
Which is literally true. It wasn't hyperbole. And if I have a duty to provide you care where you don't have a duty to me to pay for that care, I'm basically your slave at that point.
You're a slave. But we talked before about how the church and family
Yes.
and the church bears a role here.
Yes.
So a person without means, destitution is not without help.
Right. Right.
So it's just not done forcibly,
Right.
right? It's not turning you into a slave to do that. You're doing it out of duty and obedience to God.
All of the charity laws of the old covenant, if you didn't do them, it was a sin. But the magistrate, there were no civil sanctions. If you didn't allow, if you didn't allow the poor to glean from your field, yeah, that was a bad thing. You'd answer to God for it, but the magistrate didn't come and pick you up and
Yeah,
take attention on you.
and it's worth noting here, not to, we don't have time to go into it deeply, but the other big thing that the Christian worldview helps us with is that justice comes.
Yeah.
The resurrection comes, justice also comes. So the injustices that picture at the Samaritan, the Samaritan story, if the person in the ditch had not been helped justly, that there would have been a count.
Yeah.
Yeah.
So,
One thing that sort of, I think it frustrates people too. So we have these things in the past, they still come up. Let's raise money to buy a super duper piece of equipment for the hospital. And then everybody gets charged like they purchased it themselves.
Right.
And so we're all being charitable to the system, but they're not being charitable, at least for the use of the equipment in one sense. And so it was always really frustrating to see, particularly in the old system before the two hospitals, they would have these competing, and you sit there and go, okay, we're raising all this money for a piece of equipment, but when it gets into the hospital, you're going to still charge everybody. And the whole point would have been, well, there should have been some kind of discount, or
sure.
because we provided charity. I'll quote that in that, and that was always really sort of frustrating to me.
Okay. All right, number 3, and we've already talked about this profit motive. We've covered it, but I do think what the artificial intelligence told me as I punched this in was interesting. It said that the direct pay, no third party, plus Samaritan Ministries partially alleviated this because it said many bill sharing ministries are nonprofits guided by religious or community values. Direct pay providers often focus on transparency and patient care over maximizing revenue. And we talked about that, but to see that come through that source was interesting. Number 4, complexity and lack of transparency. We've talked about that one as well. And yeah, so I think there's alleviation there. How about number 5, equitable access?
Yeah. Well, like I just alluded to, even in our broken system, in an emergency situation, you will get care. But even there, people, if someone comes into the hospital, the ER, and we've seen this many times, they just don't feel right. And it turns out that when they're sick is they have widespread cancer. That's their diagnosis. They have no insurance, whatever. They will still be treated. And now, again, the way our government does it, there are uninsured monies that can come to hospitals and those types of things. And that, the end result is a nice thing, but you cannot, if you have a goal that is biblical, you can't violate God's law to get there. The path cannot do that. So that's what they do. But nonetheless, a lot of that's just modern woke language, equitable, just try.
Are we concerned about equity?
We are concerned about equity, but it's biblical equity, not equity as they define it.
What would biblical equity be?
Yeah. Biblical equity would be to love your neighbor as yourself, and that's governed by the law of God.
Yeah.
Right.
So, and what I don't think we're concerned about, and in fact, I want to argue that we don't want equity in the sense that this suggests that we might, is that as a head of household, looking at providing for my family, I want to decide what level of coverage that I want compared to what my monthly cost sharing value might be. I want to choose my provider. There might be more provided over here than there, but these things put responsibility, and I can make good decisions for my family and not be locked into a certain way of doing things.
That's a very good point you raised. To carry it further, back in the old days, there was no, as we understand it today, there was no equity. If you went to the hospital and even if you had insurance or you were wealthy, you got a better accommodation. If you were really poor, you stayed in an open ward with a curtain between you and the next bed, that type of
Yeah.
thing. You might not get the most expensive, latest, greatest heart valve. You get a good valve when they replace it, but that type of thing, that's very, very important, to bring out here is that, it's funny how our culture, they're only selective in their desire for equity. In other words, some people may be crazy to think you could do it, but we don't have equity in Mercedes-Benz purchases, right? You have to be able to afford a Mercedes-Benz.
Well, some people want that too.
They do. It's still, hopefully, it's not totally normative at this point,
Right.
and it's not a play, but that principle is definitely applied when it comes to medical care.
Yeah.
Yeah.
And number 6, employer dependence. And Michael sort of opened this up with some of the history there of how it got medical care got tied to employer, and that's not really a good thing. So the direct pay, no third party alleviates that because you can change jobs all you want.
Yeah.
If you're going through Samaritan Ministries or some other way of cost sharing, then you're not tied to that at all.
So when I first started my career, my insurance was, they paid 80, you paid 20. Didn't matter what it was, unless you got a big catastrophic something. And I bet people managed it better.
Absolutely. Yeah.
But it's an important little tangent. That's the other thing that has been bastardized is what is insurance. Doesn't matter what you're insuring historically, if this happens, we will pay you this. And the you is the purchaser of the policy, not the person who, a limb falls on your roof, you pay the roofer to fix it, but the money comes from you to the roofer.
Yes.
And then the insurance company reimburses you. And medical insurance used to be that way.
Yeah.
Oh, yeah.
And the state's role there was limited to if the three of us here cooked up a scheme where I would tell the insurance company you both had heart attacks when you did, that's clearly fraud on my part. It's a sin that should be punished and restitution made. But other than that, that's the state's only role. So if a doctor with good faith and following God's law says, yes, Dean Walker had a heart attack, then the insurance companies say, well, Dean, by contract, we're going to give you $5,000. And that's totally independent of what the doctor charged or the hospital charged. This is what we're going to do. Now, if you want to get more money, you'll pay a higher premium. And they might pay $7,500 for your heart attack. But what we have now is really a price fixing mechanism, which is not biblical either, where you have this collusion. So this is a great point, and it was worthy of discussion, is how this stuff all works.
Yeah.
And that's why we were saying earlier in our discussion how laceration of the chin leads to $1,200 stitches.
That policy in 1992 to 98, you go to the doctor, $75, you write in $75 or as the case may be.
Yep.
You filed your own insurance, attached it to it, and then they sent me a check of 80% of it back. You'll manage it better if you in that system.
And when we were all real young, the notion that you would go to a doctor's office and utilize insurance to pay for that was considered absurd, and it was. It is absurd, right?
It is absurd, yeah.
And it's because that's not really an insuranceable event. That's what I was saying, that even the concept of insurance and the definition of insurance has been bastardized.
Sure. The next two we've talked about some. Number 7 was incentivize overuse or underuse. Number 8 is limited focus on preventive care. We've talked about those to some extent and how this alternative can alleviate some of that. Number 9, fragmented care delivery. What's that all about? And can this model help with that?
Yeah, it's a huge problem. Another way to put it would be called a lack of continuity of care, would be a synonym for fragmented care. So I'm a family doctor, and you come to me with a symptom, and I determine it's something that's really beyond my expertise. Well, there may be 2 other specialties that deal with that too, but trying to get you in to see them timely, and then communicating between providers, it's highly fragmented, and very much worth talking about is that this whole thing, this defragmentation, has also led to the dehumanization of medical care.
Sure.
And that was a huge thing we saw during COVID. It was a dehumanization, especially amongst
Might also say prioritization of the
collective over the individual or the family. Right.
Yeah.
And so that would also lead to trouble. Yeah.
Right.
And this is where, it used to be personal relationships mattered.
Yeah.
you know your doctor, and your doctor knows you need to see a specialist, they would, if it was really critical, time sensitive, they would get on the phone and say, you need to see this person.
Yeah.
And those calls would be made in the late afternoon, right? Is that correct?
Well, one of the bad policy begets more bad policy and more bad outcomes. One of the other side effects here is that because we have so much third party payment, and because the hearts of the people have moved away from the gospel in our society, people have no problem with asking others indirectly or even subconsciously to pay for their care. But we now have a huge percentage, and I have many years of observation, and I would estimate, and I don't think this is far off, about a third of the patients are what we call the worried well, or they're professional patients. Their whole life revolves, and there's other sadnesses there. Some of these people are very lonely, and the medical system is their source of social interaction.
Hmm.
But to make a long story short, what this does, it clogs up the system. There's
Sure.
probably a third of the people that are clogging up our clinics and hospitals for a whole host of issues because
Wow.
they don't have a proper biblical worldview. They don't believe in the resurrection. So I'm just going to, linger in the hospital for 2 months. This prevents, like you just said, well, I need to see a surgeon. Well,
No.
can't get an appointment.
Yeah, that's kind of a little eye-opening to me because I've recognized that people even within the church have been trapped into this, so obsessed with with medical care, but I had not really connected that to the clogging up the system as you just did.
That's a
So
huge number.
it's not just something that's messed up their lives in a sense, but it's also gone broader than that.
Well, and there's an opportunity. An example in my own personal life. I mean, the gospel was shared to me by a doctor in Damascus, Virginia, Dr. Kimbrough.
Yeah.
He took that opportunity with a sinus infection and other things to share the gospel. And so there's a great opportunity for, sick people. And so the trajectory of my whole life in God's providence changed because there was other people in the past that had done it. So it was a cumulative effect, but it was that moment at your weakest point, at least it appeared to be weak, that the gospel was shared. So the whole life, the whole trajectory of my life and the kid, it's all changed because he loved his neighbor in a way that was not always expected. And probably before, in the 50s and the 60s and the 40s, doctors did that a lot.
Yeah.
And it's not probably is a common practice now.
Well, again, back in those days, you had skin in the game. You went to the doctor, and
Yeah.
even things that we consider incurable now, having a baby was not considered incurable until the last 40 or 50 years, even though insurance existed. So you have all those problems,
Right.
where it takes that. And then, of course, in fairness to the providers, the amount of time limited. When I was, with the local cardiology group here, we had always had to, resist the administration's desire for us to do 12-minute follow-up visits. I mean, you can barely say hello in 12 minutes, let alone provide. And these are not looking at someone with wax stuck in their ear. These are people with complex cardiac problems. And that also, again, ties back to the fragmentation of care. It's even within the own provider itself because they can't know you as well.
Right.
Too much time pressure.
And so the 10th one, I don't think we need to dig in too deeply. It's medical bankruptcy, and it just seems to me the more control you have over your own planning and your own finances, I have to admit, I'm out in the wilderness a lot,
Yeah.
right? And it's kind of a possibility that I might have to be rescued if the worst happens, and I worry about that. What's the expense of that? Because it's kind of out of my control in a lot of sense.
But there's an insurance policy
You
just
can
for
buy
that.
insurance for that.
Oh, I actually do. I brought that up as an example, but I do have that. So yeah, I want to kind of wrap this thing up back talking about from a Christian worldview perspective, because it really was during COVID that some of these things crystallized for me that the major problem was a problem that the government was making totalitarian decisions. That was a problem. But the bigger problem was those decisions were being made outside of a Christian worldview. And we saw that. And so coming out of that, this issue landed on my top 3 list. The church really needs to get control of this problem for the health of the individuals, health for the health of the church, and for proclamation of the gospel where we started. You know, I mean, if the church was active in this area, promoting doing it in the right way, that would be an expression of the gospel to the world. How do we encourage it? How do we get from the point where we have a few like yourself, very few, to a new model that is based on Christian worldview principles? What can we do?
Well, we don't despair, although it
Mm.
is an uphill battle, because again, everything starts with the gospel and the hearts of men. And so we have to, because there's a lot of our problems with medical care is the mindset of the people. And where, well, I just want that, and how are we going to pay for it and so forth. But as far as the church is concerned, there are many different avenues that could take, whether it's, promoting clinics, that type of thing. I mean, truly for the indigent, that's a whole separate topic beyond our scope here. But, you know, in our nation, who are the poor? Back 200 years ago, it was obvious who the poor were. Now it's not so obvious. Able-bodiedness comes into these things as well. But again, I think it starts with in the church itself is we have to get to root causes. We talked about it briefly a little while ago, but we've created this unbiblical duality where, well, we have the church here and then we have the world over here, and that is not a scriptural thing. So it starts with education of the people of God because they're not trained. They're not trained. They don't think in those terms. That somehow the state's neutral or that type of thing, and they're not. The magistrate. I can assure you, based on the scriptures, that on Judgment Day, reprobate magistrates will be judged for the laws they passed that were not in accord with God's law, and so and we need Christians to think like that because Christians do not think like that now. So that would be the first step is to teach a biblical world and life view within the church. And then the people will be better attuned to start seeing, because all of us here, we were that way too once, at least I was. And once that light bulb goes off, you see problems everywhere. Well, yeah, this violates that scripture, this violates that scripture, this violates that one over here. And as I said earlier, you might have a godly end in mind, but to violate God's law on the path to get there is not a solution. Because pragmatism is not a Christian ideal. So I think that's where it starts. Now that's a big picture. Practically, it's where you can. Yeah, I want to make it very clear. There are many fine Christian doctors who've not chosen to do what I do. It's not a sin not to do it. I'll let you lead on this if you want me to get into that a little later or now as to why they don't do it to any great degree. But having said that, it's a complicated answer because there's many spokes to that wheel as to why, especially in the specialty world, why this model has not caught on as aggressively as it has in primary care.
Right. Yeah, and I wish we had time to get into that, but I guess so. To sum that up, we do to do what? As individuals in the church recognizing this problem, what can we do?
Well, we do a thoughtful analysis, of okay, what is the best way biblically compared like we've done here in our discussion.
Yeah.
Again, not a sin to go to an insurance-based practice, but Paul said all things are lawful, but not all things are wise.
Yeah.
And so it would seem to me that where you can, and emergency care is a totally different situation because it's an emergency, but where you can, you want to try to have worldviews aligned, or at least where you have some control over the worldview that's being presented. Be willing to obey the scriptures and take responsibility for those things you are responsible for, the costs, your family, your extended family, that type of thing.
Do you think it could be driven from the patient? If enough individuals and enough patients were saying, this is what I want,
Yeah.
do you think it could be driven that
way?
way?
I'm actually seeing that now because the huge numbers of people now, especially over the last few years, have waken up to the idea that insurance is scam is probably a little strong, but it's largely a scam.
I'll let you use the word.
In other words, okay, I've had businessmen in Greene County actually say this to me. These are not paupers. These are men who employ 100, 150 people. But one guy said, I just can't. Blue Cross wants me to pay $15,000 a year for the premium. They want to throw another $10,000 deductible on top of that. And so if I don't get sick, I pay $15,000. If I get sick, I pay $25,000 before they don't render any medical care for that money. I've spent $15,000 to $25,000 for zero medical care, and they find that objectionable, and they should find it objectionable. And so people are starting to abandon it, and now it's amazing. We're probably not quite there yet, but it could be half of my patients or more actually have insurance, but they choose to come to me first because the out-of-pocket expenses are much less.
Right.
And then they figure, well, if I have a sudden heart attack, well, I'm going to meet my deductible anyhow, which is true, unfortunately.
Yeah.
So yes, but I think to answer your question, it is a grassroots phenomenon.
Yeah.
Well, we should demand market solutions
Yes.
and get government out of insurance, and then we could buy the policy we wanted.
So can you do that for us?
Well, I wish I could, but as we've
All right.
discovered a long time ago, we know what the solutions are. It's the implementation.
We just need to keep pushing. Michael, I'm going to give you the last word.
Well, thank you for doing that. Just a couple of things I think that Dr. O'Rourke alluded to about who the poor is.
Yeah.
And then we need to distinguish between the Good Samaritan poor person who has an immediate need, and we in the church need to not ask a lot of questions and help that person, right? And then once we find out more information, we may decide what we're going to do. And then we need to distinguish between that person and the person who is truly needy and the person who is just, I'm going to use a very hard word, so a person who's just lazy and they're unwilling to do what God's called them to do. And so there are those people who are unable to work and unable to take care of them because of sometimes their own circumstances or just because of God's providence. And so we have to distinguish between how we deal with those people, and we do it very poorly in this society.
Yes.
And so the person who is able to work and refuses to do anything, then that person needs to be treated, people would say harshly, but we need to love them in the manner that says, brother, if you don't work, you don't eat. And we will let their stomach teach them the lesson that it's taught us all as children. My dad goes, you're not going to do that. You don't get dinner. And so it's a very simple lesson. And he was not a Christian man, but he understood that principle. So that's one thing I think we need to do. And secondly, the charitable institutions that we do support, we need to really encourage those charitable institutions not to take government funds.
Yeah.
And I've served on lots of boards, and some of those do. And my opportunity is always to say, when you take money from the government for a charity, you're doing that by force because the government bears the sword. And if you don't pay the taxes, they will use their power to make sure they get their taxes. So if you want to ask people voluntarily to give you money, that is fine and good. And I think this is a good thing. But you should refrain from taking government money. And that's how we teach. I think first, local government officials, we should really encourage local towns and counties not to give charitable money away to anybody. Well, that should be the expectation of us when we vote for these people, or you want to do that and say, you should not do that. No matter how good you think it is, you shouldn't do it because that's force.
And it's the famous Davy Crockett and the farmer story.
Right. So
they were going to give money to widows, and the farmer said, I'm not voting for you. It's not your duty to give money to the baby widows.
Yeah, right. As important as taking care of the widows are.
Yep.
That's
right. He wasn't arguing that
yeah.
that you shouldn't take care of widows.
That's the distinction.
Someone else has to do that.
Well, thank both of you.
Appreciate it.
Thank you for preparing so well for today, and I want to thank you, Dan, for doing what you're doing. It's an example to the community. We're behind you. We want to grow it.
Please pray for the effort. And again, it's really, like I said, it's something I want to survive beyond me. And we want to have a covenantal view, or take a covenantal view of life. And that's another part of our societal problems is we just think of what's going to happen for us now. We don't think about what about the children and the grandchildren, what bill they're going to get from all this. So,
right.
But it is, we've discussed, I think we've made a reasonable case that this is a biblical model, and that's what we need to do to promote that. Yeah.
Okay. Very good.